All right. Thank you, everyone, for coming out tonight. I'm Dr. John Lohr with Science Olympiad. I'm in the national office, and I appreciate you taking the time to join us for one of our Thinking Thursday webinars. I'm super excited to introduce you guys to Dr. Teena Chopra from Wayne State University. She is a practicing disease detective. And not to mention, she's also a Science Olympiad coach in Michigan. So I'm really excited for you to hear from her about not only this topic, but have her, I'm sure she's got some great tips and insights on how to tackle the event. Without further ado, then, I'm going to turn it over to Dr. Teena Chopra, also who possesses as a master's in public health. She's a professor for infectious diseases and director of infection prevention and hospital epidemiology at Wayne State University. So, Doc, please take it away.
Thank you, John. Thank you for the introduction, and thank you to all of you, all the students who have joined today. Again, please put your questions in if you have any, and I'll be happy to answer. Without delay, I'm going to begin. And as you all are aware, you have looked at the rules, I'm assuming, and looked at what all is allowed during the event. As you know, Disease Detectives is a core knowledge event. There's a team of up to 2 students, and you're allowed to take a sheet with you, one double-sided sheet, and along with calculators, and you will have 50 minutes to complete this. Now, let's talk about the big topics that this event will cover. They will have questions and that are related to disease, to injury, to health. It will have questions around background surveillance. What is an outbreak? You know, your knowledge around various definitions around public health, pandemic, epidemic, endemic. What is an outbreak? What does an epi curve look like? And of course, patterns of disease control as well as prevention. There will be some knowledge around various little bit of math that will be included in the form of some rates, ratios that I will also go over today. So, you know, it is going to look at your knowledge. It is going to look at evaluation and interpretation. The students will have to learn to be able to define various concepts. Like I said, examples, what is an epidemic? What is an endemic? What is a pandemic? You should be able to interpret data. They may give you graphs. They may give you some data on a case report, a case series, a series of cases of patients to look at patterns, what is happening. Was there an exposure? Is there an outbreak? There may be charts. There may be mathematical, statistical terms like odds ratios, relative risk, how to interpret it. So you may be doing some math, like I said. You should be able to generate hypotheses, just like the name indicates. You want to be in detective mode, where you want to understand, okay, there was a picnic and there was food poisoning, and then this happened, you know, so many people got sick. Why did some people did not get sick? What did the people who got sick eat at the picnic? So you want to look at different clues that will be given in the question. So you also want to know patterns of disease spread. Some diseases are waterborne. Some diseases are foodborne. Some diseases are spread through droplets, like influenza, like SARS-CoV-2, COVID virus spreads through droplets. Whereas others, they can spread through water. You know, others are like through air conditioning, like Legionella disease, which causes pneumonia. So what are the various ways that the diseases are transmitted is very important. And I will give you some examples. So Let me first define what epidemiology is, which is the basis of this particular event. It is a disease of disease frequency, distribution, and determinants. So it includes all three. Frequency, there is math, how often something is happening, distribution, and determinants in a population. You measure morbidity and mortality rates to describe disease occurrence and look at risk factors. So what is it that, why in a group of people, some people got the disease and others didn't? So what are the risk factors that are unique to the people who got the disease, which we call as cases? So that is called your case control kind of study design. A cohort, which is a group of people that we are following to look at exposure, to identify the exposure of the disease. So that is a cohort study design. So whether you are looking at risk factors of disease or exposures of disease, what is the design of the study? All of this will be included under epidemiology. And what are the key aspects of disease frequency over time, place, and person? All three are important: time, place, and person. And in various forms, you can be tested around epidemiology of disease. When we say epidemiology, we say, what is the distribution of disease in relation to time, place, and person? And what are the risk factors? They are included in epidemiology. Does this disease happen in particular kind of people? And if so, what are the outcomes? Is it a very highly disease with high mortality? Does it kill you? Or does it make you sick and you recover from it? So what are the kinds of outcomes you are seeing in the disease? So all of that you want to understand when you are learning and reading about various diseases. Now I want to take a few minutes to describe some of the definitions, like what is incidence of a disease? So number of new cases of disease in a population over a defined period of time. So it is a rate at which new cases occur. And there is a formula for it. For example, you can see new cases over the population at risk times 1,000. That is how you measure the incidence of a disease. So there may be a question around incidence of calculating the incidence. So when you see the term in the question or in the statement, then you will think of new cases when you think of incidence. For example, you have a city population. You are given that there are 200 new cases of lung cancer in 1 year. So you have the numerator, you have the denominator, like we saw in the formula. So you calculate the incidence. So incidence is 2 new cases per 1,000 people per year. Now you also, let's say you are given, there could be a question where you would be asked to calculate the incidence rate, right? Using the formula, simple math. Or there could be a question where you're given the incidence rate already, you need to interpret it. So how would you interpret it? So 2 new cases per 1,000 means that 2 out of 1,000 people in the city are diagnosed with lung cancer every year. So you need to be able to interpret it as well. So evaluate, interpret, and understand the statistics around it. Now that you've learned about incidence, how does it differ from prevalence? Prevalence is the total number of existing cases of a disease in a population at a given point in time. So it's the total burden of disease in a population. So we talked about incidence, new cases, prevalence, total number of existing. So it will include old cases of that disease too, remember? And the new cases. So it will be the total cases divided by total population times 1,000. Again, you have a population, you've given the total city's population, and then you're given people with lung cancer. So that will include both new and old cases, and that's 1,500, and you divide 1,500 by the population times 1,000, you'll get 15 cases. Now let's say you are given a prevalence of a disease and you have to interpret it. What does that mean? So at the time of measurement, 15 out of 1,000 people in the city are living with lung cancer. So that's how you will be interpreting your data. So you've learned about incidence, you've learned about prevalence. These are basic rates that you use in epidemiology. And a lot of times, many questions will show you some of this data. Now I want to switch gears, and I'm focusing a little bit on the statistics because this is something that is harder for students. So I want to show you this 2x2 table, which is a very common tool that we use in epidemiology and statistics. And we look at various outcomes. Initially, in the beginning, I told you about outcomes in epidemiology, right? And I also told you about exposure. So we have a population of patients who were exposed, to it could be anything, and then they had a certain outcome. So you are using this cohort of patients to look at their exposure. There is a patients who have a disease, all the patients have the disease, and you want to understand what were their exposures. What were they exposed to? The exposure could be to antibiotics, for example, right? And you could see some patients could have been exposed to that antibiotic, others could not, they were unexposed. And then you measure their outcomes. Outcomes could be whether they had disease or not. So this is one way of doing a study design, like in a cohort study design. And the tool, the measurement tool in this study design is called relative risk. And you use this formula of relative risk where you look at the outcome rate in the exposed population divided by the outcome rate in the unexposed population to calculate the relative risk. So of that particular exposure. So how important is that exposure? So for example, the outcome rate in the exposed is A is the one that are diseased and exposed divided by the total patients who were exposed. This is the outcome rate in the exposed population. So A divided by A plus C. And outcome rate in the non-exposed population would be B. They were unexposed patients. They were not exposed to antibiotics, but they did have that disease. So you divide B by the total unexposed, and that will be the outcome rate in the unexposed population. And then both the rates, you divide them to calculate a risk. Outcome rate in exposed divided by unexposed, and that will give you a risk measure of that exposure that you're looking at. So how do you interpret it in a very simple way without getting into the complexity? If the relative risk is 1, which means that the outcome rate in exposed divided is also, 1 divided by 1, it is 1, right? The outcome rate in exposed is equal to the outcome rate in the not exposed population. Then how do you interpret it? So then the risk of disease is same, right? In both exposed and unexposed population. So the exposure that we are looking at, that we are trying to measure, is not associated with the disease. So that is how you interpret it. If the relative risk is greater than 1, that means the numerator is greater, right? Then the exposure is positively associated with having the disease. And that could be a risk factor for the disease. If the relative risk is less than 1, then it's the opposite. Then the exposure is negatively associated with having the disease and could be a protected factor. So you want to simply remember this interpretation of relative risk. And you may want to go over it again and again to get an understanding of it. Similarly, we have another tool that you may get in any of your questions. It's called odds ratio. In this case, the 2x2 table, you look at the disease and then you look at the patients who have disease are called cases, and patients who don't have any disease are called controls. So you use odds ratio in a case control study. And it is used mostly in retrospective studies. Basically, you have a bunch of patients who, for example, let's take the example of a disease like COVID. Okay. So we have patients who are hospitalized with COVID at a certain period of time. And I want to understand what were their risk factors. And I look at another group of patients who also came at the same period of time in the hospital, but they did not have COVID. And now I want to look at the risk factors, right? So my cases are patients with COVID and controls are patients without COVID. I match them. I can match them by time period of admission. So I am using a design of study called as case control study. And the tool that I will use to measure is called odds ratio. And I'm going backwards in time. I already know I have patients who have disease. I'm going backwards in time. So that's why it's a retrospective disease study. And in this case, we cannot use the relative risk, but we use something called as odds ratio. And in odds ratio, you calculate the odds of exposure in cases and divide it by odds of exposure in controls. Again, you make your 2 by 2 table in which the outcomes are over here and exposure is over here. And basically the odds of exposure in cases is, this is your case with disease and exposed divided by number of cases with exposure divided by number of cases without exposure. So A divided by C. So I'm going to go back a little bit and I want to go back to the 2 by 2 table that we used in the relative risk. Here it wasn't A divided by C. Here it was A divided by A plus C. So here the outcome rate in exposed was A, the ones that were exposed, divided by total exposed. So it is different than what we use in odds ratio. So here it's A divided by C, whereas exposure in controls is B divided by D. And then you divide these ratios because we are calculating a ratio, odds of exposure in cases. In other words, it's the cross product of this 2 by 2 table, A times D, B times C, divided by B times C. So I'm explaining all of this to you because it all depends on how you make your 2 by 2 table. If your outcomes are over here and exposure is here, this is the cross product of the 2 by 2 table. So you do want to understand how you are interpreting it. Again, interpretation of odds ratio is also another important tool that I think all of you students should know. If the ratio is 1, that means odds of exposure amongst cases is same as that in controls, and that means exposure is not associated with disease. If it is greater than 1, odds of exposure among cases is more than odds among control. And if it is less than 1, then odds among cases is lower. Again, it can be a protective factor. Okay. So now I am going to switch gears. And of course, what I have gone over about case control studies, cohort studies, odds ratios, relative risk, it is not inclusive of a lot of other things like, for example, definitions of pandemics, epidemics, other definitions of rates and ratios, which I would expect you to go over. So given the time, I could not include everything, but I have tried to include things that are extremely important, and the terms are a little bit complex, and interpretations that I wanted to include so that you understand them.
Hey,
Steps in an outbreak. Yeah, go ahead, John.
pardon me. There's about 5 questions that have to deal with risk and odds ratios and stuff. So would you mind if we pause and took those before we get too far away and
Sure.
start talking about the investigation?
Go ahead.
All right. The first one is, and I think you touched on this, but could you just clarify, how do you know when to use a risk ratio, relative risk versus the odds ratio?
That's a great question. So, like we were just talking about odds ratio. So, odds ratios, you will have clues in the question like it's a case control study, right? and you are looking at you're looking at patients who have had disease, and you're looking at patients who don't have disease, and you're going backwards in time to look at the exposure. So if you have those clues in your question, then you have to, odds ratios are important in case control studies.
Okay.
And whereas relative risk is important in cohort studies, So the study design, I would urge you to go through various study designs. And that will really help you understand when to use what. But overall, bottom line, for case control studies, you use odds ratio, and for cohort studies, you use relative risk.
Okay, so, and just to double check, because this is, and that touched on a couple of the questions, and Shiv here says, so to clarify, essentially relative risk is when the studies are actively going on or the situation is actively happening. And odds ratios tend to be more for studies that have been completed, or you're kind of looking back on a incident. Is that a fair description?
That is a fair description, but obviously at this level, I think it is a fair description, because you are right, Shiv is right, that case control studies are retrospective. The cases have already happened, the disease has already happened, and now you're going backwards in time. Whereas in relative risk, you can just look at a cohort of patients, or a group of people, individuals, and you can look at their outcomes. And you want to look at their, it's a cohort. So you're not comparing the cases to the patients who don't have disease. In a relative risk situation, in a cohort study design, you're only looking at patients who have disease, and you can either go forward in time or go backward in time. So that is getting into a little bit higher level. But yes, for the most part, in a cohort study, you will be looking at the relative risk, and case control, you look in the odds ratio.
Fantastic. All right, two more quick ones. And I'm assuming when the question is, why do you multiply it by 1,000 when calculating incidence?
So that's also the case with prevalence. You multiply it by 1,000 because that it is a rate. We are talking about it as a rate, and in a rate there are times that you can use a different multiplication, but it makes it easier to understand. For example, you are looking at lung cancer, and you are saying for every 1,000 people, 15 people have it. Given the size of the population, you are using a general 1,000. If you are dealing with a very small, tiny population, then you may not be using 1,000. But given the size, that is the number you use. And it's pretty standard for both incidence as well as prevalence.
Okay, sounds good. So just use it. It's kind of the accepted number for these kind of calculations. Then looking here, and I think hopefully I get this right. It's Sukata asks, in the 2x2 table, can exposure and disease, the column and the row fields, be interchanged?
They can be, but
Okay.
you will have to, you can interchange them, yes, but you cannot change this. So odds of exposure in cases will always remain as number of cases with exposed divided by number of cases without exposed. So the reason I kept them like this, and then I said it is the cross product to make it easy for you. If you have a 2x2 table with outcomes here and exposures here, then you don't have to go through all this. You can just cross multiply and you will get your answer.
Okay. All right, thank you. Sorry to interrupt, but that cleared the questions for the moment. Why don't we get into the next part, talking about how do you do the investigation?
Sounds good. No, this is all great questions, and I'm so proud of the students. They are paying a lot of attention. So now let's go to an outbreak investigation. The very first thing in an outbreak investigation is you have to first determine if there is an outbreak, right? If there is an epidemic happening in your area, whether you are in the hospital, in the community. And I'll give you an example. I'm a hospital epidemiologist, and I've dealt with multiple outbreaks. So let's talk about a disease. Like, for example, one common disease in the hospital is C. diff. C. diff is the full form of C. diff is Clostridium difficile. It's a Clostridioides difficile. It's a bacteria. It's a gram-positive bacteria which causes diarrhea. And it is the most common cause of diarrhea in the hospital. And it basically happens very commonly in the hospital because we give a lot of antibiotics to the patients. They are sick, and exposure to antibiotics is a risk factor, known risk factor. So let's say my nurse comes to me and tells me, this month we've had 7 cases of C. diff in the hospital. So what will I do first? First, I'm going to look back in time, the whole year, and I'm going to look at my rates of C. diff. And I'm going to look at every single month. And I'm also going to compare the rates to, let's say my nurse came to me in the month of November. We are in November, in October. She tells me October, we had 7 cases of C. diff. I will go back in time, 1 year at least, and look at every month and look at my rates. Were my rates, what is that my average? Where am I averaging? And if I'm averaging at 1 to 2 cases per month, and in this time in October, I have 7 cases, that's pretty high for me. So then I will go back and look at what unit the cases happened. Were they in one single unit? Because that will also tell me that there has been transmission in that unit. If they were restricted to a unit, were they restricted to a physician? Were they restricted to one nurse taking care of all 7 patients? Was she not washing her hands? So the first thing I'm going to do is gather more information, establish if it was an outbreak, were the rates more than usual? And then I'm going to, in my second step, when I said I will verify the diagnosis, which means I will look at the definition of C. diff. I will look at whether the right appropriate test was used to diagnose these patients and confirm that these are C. diff cases. That is called confirmed case. So there is a case and then there's a confirmed cases. Confirmed is confirmation by their diagnostic test. C. diff is diagnosed by a PCR test of the stool, and I will confirm with the lab whether that test was used on all these patients. And sure enough, if it was, then I have confirmed that there is an outbreak. And then I will make a line list of my patients. The 7 patients that I talked about, I will look at their characteristics, their age, their demographics. I will do something called as descriptive epidemiology. I'm using the example of C. diff and I'm walking you through all these 10 steps. So now I've already verified my diagnosis through the PCR. I have made a line list and I'm using descriptive epidemiology, which means time, place, person. So which patients what are these 7 patients? Are they all women? Are they men and women both? Are they particular age group? Is it my older patients? What age group are they? What unit are they admitted in? And what nurse was taking care of them, what physician was taking care of them. I'm trying to detect and determine why did this outbreak happen, right? What is the common source? Is there a common source? Is there a nurse who's not washing her hands? Is there unnecessary antibiotic that was given to my patient? So all those risk factors, all of those things I will start. Then I will reevaluate all my cases and I will come up with a hypothesis and what happened. Were my C. diff patients not placed in an isolation room because they are required to be in an isolation room so that there is no transmission from one patient to another? So my hypothesis is probably one of the patient was having C. diff and having diarrhea, but the C. diff is a sporulating organism, and maybe the environment was not clean. They didn't clean the room of the patient appropriately and placed another patient in the same room who also got C. diff. So maybe that is my hypothesis, right? So how will I evaluate that? Now I am at numbers, now I am over here. So I've talked about epidemiology, I've talked about which kind of patient is getting sick. I have developed a hypothesis and I'm evaluating my hypothesis. And I'm trying to, I find out that the room was not clean. So what do I do next? To reevaluate my hypothesis, I go to the EVS chart, EVS audit. EVS is environmental services. I look at their audit and I look for the fact if the room was in fact cleaned or not cleaned. And then I this is my additional studies that I'm conducting. And that's when I try to implement infection control measures. What is my infection control measure? That as soon as the patient is diagnosed with C. diff, they have to be placed in a private room. The room has to be cleaned, and there has to be strict contact isolation precautions, which include wearing gloves, gowns, all PPE, washing hands before entering and leaving. And I am going to have audits in place where I will have secret shoppers who are looking at healthcare workers washing hands before going and coming out. So that is where I'm implementing my measures. And then I will write a written report and I'll submit it to the quality department in my hospital. So that is how I'm going to conduct an investigation, and I'm going to stop the chain of transmission of this organism that is spreading from one patient to another. So again, the various steps include establishing that it has been an outbreak. You can make an outbreak curve to determine, and I'll talk about it, how to make an outbreak curve, how to define what different kinds of outbreak curves are. And then I have verified my diagnosis by conducting the diagnostic test for C. diff, which is a PCR, and I've established that these are my confirmed cases. I have made a line listing of my cases. I have defined their descriptive epidemiology. I know which unit they are from. I also know who is at risk of falling ill. These 7 patients belong to one unit, and this unit is my geriatric unit in my hospital. And I have developed a hypothesis that probably the room was not clean. Then I'm evaluating it through the help of my environmental folks. And then I'm conducting additional studies. I'm implementing changes so that I can stop the chain of transmission through in control and prevention measures. And then the last step is to write the report and communicate the findings. So, John, I noticed there are questions around it. Do you have anything for me before I move?
Yeah, I do. There's actually two here. But I think that the first one we're going to wait on, and we'll capture that one at the end, because it goes back to the talking about studies. But one student asked, they see, in looking at, they see you got a 10-step up here. They've also seen 13 steps. Does it really matter in terms of the steps?
It doesn't. What matters is the important steps. They may have expanded some of the steps. So what matters is that you have to define your case. What matters is you have to verify the diagnosis. You have to have a line list. If you are looking at the cases, you must establish where is the point source. So some steps are very, very important. You can't move from establishing a outbreak to developing a hypothesis without confirming a case. So this does matter. Some of these steps do matter. You can't jump from verify the diagnosis and then go to infection control. You can't jump from 2 to 9. But as long as you have a basic understanding of the steps, even if you have looked at a different format and looked at 13 or 14 steps, that's fine. But you do have to go through this stepwise process so that you don't miss out on important details of the outbreak.
Yeah. And I think for the students out there worried about this, if I was running this event, I wouldn't waste one of my questions asking you about the number of steps or asking you to tell me the 13 steps. The important thing here is what Dr. Chopra is talking about is the what is happening and what are the key things you need to do to understand an outbreak investigation or to prevent, an outbreak from continuing. So that's the place where I would be focusing my time and energy, is making sure I understood that. There's one more question in here, and this is dealing with your example with the C. diff, right? And it says, what if there are no past cases about C. diff, or it has happened more than a year ago? How do you handle it?
That's even easier for me. If there were no past cases, then I'm pretty sure something really fishy is going on. Why am I seeing C. diff now? Suddenly. So I will declare it an outbreak right away if I have 0 cases. And I wish that was true. But our goal is to have 0 cases, but that really doesn't happen in the real world setting. But yeah, if according to your scenario, if I had 0 cases and I suddenly have 7 cases, then it's a big, big problem for me. I'm even more sure that I have an outbreak.
Yes. And it's definitely a problem, because I love how you describe C. diff as, oh, it's diarrhea. It's way worse than that, but I will let you continue.
Okay, guys, let's keep going. So I think I went through all of these, but I have them again just to give you a further breakdown. So you want to verify. Every disease has a way to verify, right? The first way to verify is you look at observed cases if they exceed the expected number. In your case, you told me it's 0. So clearly you have an outbreak. And then you define the criteria. Always these are your favorite friends, who, what, when, where, right? Is the case, does this outbreak happening in a picnic, or does it happen from a common well that the villagers are using water from? And then you need lab diagnosis, and they often ask you what's a confirmed case, and that means that a lab has confirmed that this is the disease, like for C. diff, it is PCR. Then you develop a case definition of the case, just like when SARS-CoV-2 hit us. CDC defined it. What is a case definition based on clinical data, epidemiological data, lab data? And then you collect data on suspected, probable, and confirmed cases. So usually your probable cases will be much bigger in number than confirmed cases. And in a case scenario at Science Olympiad, you may be given 2 different numbers. You may be given 3 different numbers. You may be given numbers of probable cases and numbers of confirmed cases, and you may be asked to calculate a rate. Describe the outbreak. You can describe it by time using an epidemic curve. You may be given 7 or 8 cases, and you may form a table with a series of your cases and look at their patterns and clusters. The patterns can be, maybe they're all women. They are mostly women, or maybe they are mostly children that are being affected in a particular table that you are given. Also identify clusters. Clusters can be according to time, maybe season of the year that you are seeing a particular disease, or maybe they are clustered by geographical location based on the exposure. So it could be really anything. And that's what your eyes have to try to determine in the data that you've been provided. And then you develop a hypothesis. What could be the potential sources and modes of transmission, like I told you? It could be that, like for example, John Snow, when he identified and investigated the cholera epidemic in 1840s in London, what was the mode of transmission of the cholera epidemic? It was the pump that had the contaminated water. So that's how, Jon Snow is famous for. Investigate what are the exposures, risk factors, and common factors. Then you test your hypothesis by conducting studies, whether you are doing case control studies, right, or cohort studies to test your hypothesis. And then you With your statistical tools, you look at associations, whether it's odds ratios or relative risk, and you look at associations between exposures and outcomes. And then you come to the stage where you want to break the chain of transmission. How do you do it? You isolate patients, like I said, with C. diff. You vaccinate them. You wear masks if it is a respiratory virus, droplet infection. You make sure the rooms are cleaned, like I talked about, environmental cleaning. And you provide all public health recommendations to prevent further spread. Currently, we are seeing a lot of outbreaks of measles and whooping cough. They are very common right now in the nation. So know your current events, your diseases that are spreading. Why are they spreading? Why is whooping cough spreading? Why is measles spreading? Because there is decrease in herd immunity from measles because childhood vaccination rates have fallen. So measles is another disease that can very easily spread. It is even more contagious than SARS-CoV-2. Measles is the most contagious disease on the face of the earth. Then you report to relevant stakeholders. You communicate your information with the city, with the state, with the health departments, and communicate it to the general public so others are aware. And then you obviously, last but not the least, write it down, document what you have found so others can learn from it, right? So let's look at epidemic curves. They are very, very important. They are graphs that help display the number of cases per time unit during the period in which the outbreak takes place, and they help validate hypotheses on various agents that may be causing the disease, and they talk about the incubation period as well. So let's see the most common kind of epidemic curve is the first one right here, which is a point source. And it's a typical bell-shaped curve case. There is an index case, and then there is a peak, and there's a fall. And they're very common with your food poisoning is a typical example. Cases of salmonella can happen like this. You know, there were cases of other kinds of staph aureus food poisoning can happen. There's one case and it starts and then it falls, and it only includes one incubation period. So this is your typical epidemic curve. And then you have two others. There is a progressive source where there is evidence of person-to-person transmission. And, in this one, it is very common example is measles. In this, what happens is that there is a person who exposed several other people, so there can be multiple peaks, and then a couple of peaks are there, and then it falls, and then there's another peak because the other person who was exposed and had the disease now exposes a bunch of other people, and ultimately dies down because either all the people who were potentially at risk were exposed and they had the disease, and the disease died down, or there was a break in transmission of disease by removing the exposure. So the exposed person was removed from there and it went away. So this is called progressive source, which is person to person. And then there's another one, there's a continuous common, in which is multiple peaks are there. Again, one of the examples is cholera with example when the epidemic happened from a common pump in London, where John Snow investigated the outbreak. It's very common to have a common source, continuous common epidemic curve. Again, it can have multiple peaks here. So these are various examples of epidemic curves. You can be given an epidemic curve. I'm sure you have looked at some of the previous examples, and you should know about what they are and what do they mean, and also how to be able to interpret them is important. Various kinds of epidemic curves are really important. So, again, I should mention that I haven't covered every single thing in Disease Detective, but I have covered things that are common and that are practical that I use in my daily life as an epidemiologist. So let's look at some of the big picture coaching tips here. Of course, you will look at the presentations, handouts. You will learn about various study designs. What are the advantages, disadvantages? What statistics you are going to look at? How can you calculate the odds ratio? You will prepare your binders, and I'm sure you are already working on it. You will also be preparing your reference sheets and putting on things that you may want to don't want to memorize and want to have them as a quick guide, any diagrams, any formulas that you are that you may forget, you want to put it on there. And you want to partner with your teammate, and you can decide how to uh, tackle which problem and then be efficient when you are doing it. How can you apply concepts that you have learned, what study design can be suited for studying rabies, for example, and why. Looking at various kinds of statistics, I think we've really hammered on it a lot. Then review your progress, identify topics for review. Um, Remember, this event is very much about evaluation and interpretation. It's not a memory kind of event, but as long as you understand the various designs and steps in an outbreak, you can do very well on it. So this is again another a cartoon to remind you of the levels of knowledge and question types from Science Olympiad, how you can look at various kinds of data and how you can interpret it and make judgments based on it. So another tool for you. I talked a little bit about case series. Case series is a list of cases, basically. Like I said, I had 7 cases of C. diff, right? So those 7 cases, I put them in a table format. I put their age, I put their sex, I put their did they have diabetes, did they have hypertension, their comorbid illnesses. I also put at where did they come from? Did they come from home? Did they come from nursing home? I put all the information I can about them. Um, and then I evaluate it. I find patterns. What is common in these patients? And I actually did this, I can give you a real example. During the pandemic, I had nine patients who had COVID and C. diff together. They had co-infections. And I published the first case series of patients with COVID and C. diff co-infections. It was published in a CID journal. And they were predominantly women. And out of the 9 patients, 5 of them ended up dying, and they had very severe infections because they were co-infected with. And what we found were they were mostly older patients. So based on just the case series of these patients, we were able to understand that older patients have lower immunities. They are more like if they have co-infections with 2 different a virus which is very deadly and a bacteria with like C. diff. I mean, imagine what it will do to the immune system of an older patient. And we were the first hospital to report this infection in the nation and tell other people how they must look for other diseases along with COVID when a patient comes, because that can actually add to their illness and can kill them. So, everything you do, there is a reason why you are doing it. So case series seems like a very simple study, but it can really help make further studies and help with the fund of knowledge. Um, so again, there are other questions that are listed here that have been given in other invitationals that can also guide you as to what kind of questions you can be asked. There's one question about COVID booster uptake in US that went up from 57 to 80%. List 4 strategies that the government can use to encourage more individuals. Now, this question is really not about the percentage of, the percentage has been given there not to scare you or anything, not to ask you to calculate anything, but to think about from your reading, what can you do to help increase booster compliance amongst individual. You can talk about educational means. You can talk about vaccination campaigns. You can talk about having a vaccine ambassador program in your community. You can talk about connecting with your populations, with your communities through breaking barriers, language barriers, cultural barriers. You can also talk about mobile clinics. You can take the vaccine to the patients who cannot really come to you. There are so many things that you can do to boost compliance. So that's all you have to list there. You know, a lot of these are common sense things that you can think of as you move along. So I think this is it, John.
Yeah, no, fantastic job. And guys, there's some resources and stuff, but we have a couple of questions here. I want to see if we can knock some of them out, if that's okay with you.
Sure.
All right. Sumlina asked, can you talk about the like when you might want to use a specific study design? So particularly like case control versus cohort. Is there any reasons like one study's better than another?
Sure. You know, when you have a list of, it all depends on the question. So, uh, you could be given a bunch of cases, right? And you could be asked what kind of study design you want to use to understand their risk factors. Let's say you are given uh, cases of MRSA infections in the community amongst a group of individuals. So you want to uh, understand their risk factors. So to do that, you want to match those cases with controls who don't have the infection. Um, why did they not have the infection, even though they are also the same community? And so now you are trying to look at their risk factors and you are matching them with control. So this is called a case control study. So that's how you decide what kind of study design. So it all depends on your question
Okay.
that is given in the event.
All right. Then real quick, so we talk about suspected, probable, and confirmed.
Sorry, John. One more thing I can give you as a clue. If you're looking at rare diseases, then you can overall case control is a good sort of way to look at exposure. So if you're looking at rare diseases that are not that common, then I would use case control studies because begin case control studies always begin with people who have disease. So if there's a very rare disease you are studying, you know, you start, you think of a case control study design. So it's a good clue, good hint for you to take when you want to pick your study design.
Okay. All right. Moving to another one is the questions asked about the difference between suspected, probable, and confirmed cases. Is it just about the information that you have, or what causes you to shift from one to another?
Yeah, it's based on the information. So for example, you will be given there was a gathering where there were cases of Legionella pneumonia. And the investigators conducted an investigation. When they conducted an investigation, they found there were overall 100 people who attended the event. 50 of them had, or 80 of them were suspected to have the disease. Out of them, 50 were confirmed. So when I say confirmed, they had their sample given to the lab and confirmed that they had Legionella pneumonia. But when I say suspected, it was 80 people were suspected, but not everybody had a positive test. So only confirmed cases had a positive test.
Okay. Um, Here's a question from Jing Yi, and they mentioned that from the very beginning that's the question, it comes from something they've been studying that they were hoping to get some clarification on. And it is, can you talk a little bit about the difference between vaccine effectiveness and efficacy? And are there any particular formulas they should pay attention
to? Did they mention any kind of vaccine?
No, I think just the general concept. Is there a difference between, like, if you talk about vaccine effectiveness, is that different from vaccine efficacy?
Yes. So vaccine efficacy is actually measured in a clinical trial by comparing the number of cases of disease in the vaccinated people to the placebo people. So that is efficacy. So people who got placebo versus the number of cases of disease in the vaccinated group. Okay. And effectiveness is how well the vaccine works in real world conditions where clinical trials may not be like a perfect representation of the population. So for a vaccine to be approved, for example, the vaccines should have an efficacy rate of at least 50%, but their effectiveness can differ, you know. So if you think of clinical trial, think of efficacy. And if you think of real world, how effective it is, that is effectiveness. That's a
Okay.
great question. Yeah.
That's a great distinction there. All right. So I think this has to be our last one. And this topic's come up in a couple of the questions that are still out there. And it's when you talk about kind of source of infection, is there a difference between a progressive source and a continuous common source? Or how do those kind of sources differ?
Yeah, I mean, continuous common is like, a pump which has contaminated water. That's continuous common source, right? A progressive source is that which you haven't removed, an exposure that you haven't removed. If you remove it, it won't be progressive anymore, you know? So there is a bit of overlap, but that is a good way to differentiate.
Okay, so thinking back to your pump example, is if we had there's some kind of bacteria growing in the water in the pipes in the water fountain. Everybody's going to, anytime you go, you're kind of getting, because you're getting the same exposure, because everyone's pretty much getting the same amount of water and it's coming from the same fountain. And with a progressive source, it'd be just kind of showing up initially.
Progressive sources, like, it is, for the one example of progressive is measles, like it spreads from person to person rather than from a common source. So
Okay.
you are right that continuous sources where people are infected over a long period of time because there is polluted drinking water or the food is spoiled over a long period of
Yep.
time. Best example is polluted drinking water, but progressive is when person to person. There is person to person, which could be measles as a good example. If you don't remove the person with measles,
Yep.
there will be progression of spread. Also, since it is so contagious, the person who has spread, the index person, and then the second, that person has spread to so many other people, all of those people will become potential sources of progressive spread.
Yep. Nope, that makes sense.
Until you contain them, it will keep spreading.
It keeps spreading.
Or
Yeah.
or it will also, there is another way of it to stop is when the disease dies down, when there is so much of spread that there is a herd immunity.
Okay.
Yeah.
Yep. All right. Well, thank you, everybody. And please thank Dr. Chopra for taking the time. Wonderful presentation. Love the stories and the real world examples. It was fantastic. And to everybody, thank you very much. Couple of things to keep in mind. Like I said, everyone will get the recording so you can watch it again. We also have some unanswered questions. We'll see if we can get answers to those. And if we do, we'll go ahead and we'll post them on the disease detectives pages. at soinc.org. Again, thank you very much to Dr. Chopra. And again, guys, have a wonderful night, and I wish you all the best this season.
Thank you, John. Bye-bye.
Bye.